Good afternoon, ladies and gentlemen. My thanks go out to the organizing committee of Amasicon 21 and especially to Professor Debrushi Sharma for giving me an opportunity to speak in front of you today. When I was asked to speak on this topic, it appeared to be a run-of-the-mill lecture, but that was then. Because when I started to research on published articles on eTEP approach for inguinal hernia, to my utter astonishment, then dismay, and finally chagrin, I realized that it would probably be easier searching for a needle in a haystack because there's an acute dearth of articles on this topic, while there are plenty and plenty of articles and comparative studies on the eTP approach for ventral hernias. So why do we need a new procedure or a modification in an already existing one? Obviously, there must be some shortcomings regarding the technicality of procedural steps or difficulty in replicability, or the results are suboptimal. When we talk about endoscopic inguinal hernia repair, one of the cornerstones has been the standard TEP repair, time tested and nearest to an anatomical and physiological repair. But a few hiccups still remain with this procedure regarding the long learning curve, restricted and limited port setup, limited surgical field of space with the resultant poor ergonomics, low tolerance to pneumoperitoneum, and difficulty in teaching to others. Come 2012, and in steps a new procedure, well, actually a modification in the standard TEP, and that is the eTEP, Enhanced or Extended View TEP, the new kid on the block, courtesy Spanish surgeon Jorge Dais. It was initially for inguinal hernia. But, there's a big but, does the eTEP solve any of the problems? Does it present comparable data? And are there problems even with this procedure? Now, problem in addressing the above concerns is the paucity of comparative studies. Few studies that are available are prelim reports of individual experiences. Now, we managed to identify a few relevant papers. Three prominent papers are by the originator, that is Jorge Dais. They are published in highly indexed journals, and the rest are small series of prelim reports and only one a comparative study with a standard TEP. The complication rates, the conversion, the recurrence were reported were comparable, but the difference in the operating time was startling. While Dice reported an average of around 38 minutes for his unilateral inguinal hernias, all other studies reported a 2 to 4 times higher operating time, extending from anywhere from 1.5 hours, 1.2 hours to almost 3 hours in certain studies. When we looked at our data of eTP in our comparative study on eTP versus TAPP, we found our time to be comparable with that reported by DICE, and we had a unilateral operating time for unilateral hernias of around 46 minutes. The other parameters, namely the injury, the complications, the recurrence rate, and conversion rate, were similar to what were reported by the original study by DICE. And when we compare these data of eTP with our data on TAPP in our ongoing study, along with SILS TAPP, we found that the data was comparable. The operating time was not much different. The complication rates were not much different. The complication rate, the recurrence rate was not much different. The conversion rate was not much different. So the next logical step was to compare the standard TEP figures with the eTP figures. And for that, we took the help of the eTP figures of ours and the reported publication of DICE, along with standard TEP of recent publications and 2019, one from All News Medical Sciences, the second was a Cochrane meta-analysis, and the third was a pilot trial of 2019. And what we found was that the operating time across all these studies, the eTP and the TEP that we managed to pull out from the reports, was not much different. In fact, the eTP reported operating time reported by us and by DICE is slightly less than that reported by this for the standard TEP in these studies. Similarly, the total complication rate, the recurrence rate, and conversion rate was comparable. Now, so the results of eTEP are probably comparable with those of standard TEP and TAPP. Why do I say probably? Because I may be faulted because I've not made a statistical analysis of these data, but they appear to be more or less similar. So once we agree on that, are there advantages with eTEP option? And for that, the anatomical and technical advantages of eTEP need to be spelled out. Number one, that what we're doing in a eTEP is establishing a continuity between a larger and longer retrorectus space and a prepetal space. If you look at this figure, the umbilicus is out here, and you have this in a standard TEP. The first port is infraumbilical, and you have a very small retrorectus ring. Compare this to the eTEP approach, where the first port is supraumbilical by about 3 to 5 centimeters, and you've got a very long retrorectus space, which then becomes confluent with the prepetal space. So this whole becomes one flowing area, the area demarcated in the yellow lines. Number two, the unique and remarkable freedom in positioning the first port. You've got multiple choices to it. At any side shown in the purple transverse lines, just medial to the semilunar line, there's a lateral border of the rectus sheath. It could even be placed more laterally outside the rectus sheath, but there the chance of damaging the peritoneum is much more as compared to when you put the port within the rectus sheath. If you want to be more anatomically specific, then you have to stay inside the rectus sheath, number one, and number two, you have to prevent any injury to the infraepigastric vessels which are lying inside the sheath. And for that, the positioning is important. And first is the lateral position. The lateral, it has to be 3 to 5 centimeters lateral to the midline to avoid possible injury to the infraepigastric artery. And cranially, it could be placed anywhere along this line. The 3 to 5 centimeters is an optional and optimal, both optional and an optimal site where you can put in this port 3 to 5 centimeters above the transumbilical line. Care has to be taken that you don't, the instruments don't collide with the costal margin. And then on the side of the posting, side of the positioning of the first port is again important. It can either be ipsilateral or it could be contralateral. So that gives you a lot of freedom for the first port. Similarly, there's a great variability in position of the third port also. The second port is constant. It has to be in the contralateral iliac fossa, contralateral to the side of the hernia. The third port, that is the umbilical port, can either be infraumbilical on the ipsilateral side of the first port, contralateral side, or on the contralateral iliac fossa side. The care has to be taken that you have a proper triangulation between these three ports. So this variability of the third port and the variability of the first port is very, very characteristic in a TEP. The next thing which is very important, is that the prepetal space that you have can be greatly expanded more easily as compared to standard TEP by just transecting the arcuate line of Douglas at the lateral and the medial edges. These corners can be transected. You can increase it, transect for about 1 to 2 to 3 centimeters, and that increases the whole prepetal space as demarcated here by the green circle. Compare this with the black circle, which is the standard TEP vision that you see in when you're doing inguinal hernia repair. Better seen and better can be seen with this view. You find that there is a bird's eye view. You can see everything retropubically as compared to the TEP view, where the vision is slightly more restricted. The expanded prepetal space also gives a clearer anatomical delineation and vision of the arcuate line, the distal prepetal space, the infraepigastric artery, and the posterior surface of the rectus abdominis muscle. So, in favor of a eTEP versus TEP, with all these armed with all these facts that we just now enumerated, the larger opened up prepetal space enables us to ergonomically better maneuver our instrument, just like in a TAPP procedure, where the maneuverability is very, very easy. So you have an optimal intra versus extracorporeal length. You have an optimal manipulation angle and the azimuth angle. You have an easier placement of a larger mesh, 12 to 15 centimeters, as compared to a patient where you have a standard TEP, where you put in a 10 to 15 centimeter mesh. you have a better tolerability of pneumoperitoneum, and it allows unencumbered proximal dissection of the sac and peritoneum, which is an important fact when you're dealing with large inguinal scrotal, sliding, or incarcerated hernias. Ergonomically better and easy suturing ligation if required, especially when you have a peritoneal tear, or you have to anchor the distal part of the sac with the undersurface of the abdominal wall to prevent a postoperative seroma formation. And the TEP is much more easier to learn and master, and should form a good starting point for residents to learn a TEP repair. Now, with these advantages, certain other additional indications for eTEP crop up, as I just now enumerated, especially in obese persons where the panniculus is laden with fat in the infraumbilical area. So creating the eTEP port in the supraumbilical area becomes much more easier. A better procedure for a post-bariatric patient, patients with short pubumbilical length, where a standard TP you have clashing or crowding and clashing of instruments, and in patients with previous pelvic surgery with infraumbilical scars. So in conclusion, we can safely say that if your MI technique or minimal invasive technique, especially standard TP, allows you to establish the critical view of myopectoral orifice, you do not need to change it. But at the same time, an eTP access opens up a whole new dimension of more freedom of technicalities, more ergonomic maneuvering, more ease of mastering by residents and surgeons in training. And that is why we say that it has a place in the armamentarium of the hernia surgeon, more so because it's just another way of putting the first sport for a standard TEP. Thank you for your time. For more educational videos, you can always visit my Prime channel, that is Raif Sena JHS. Thank you.